Thank you so much, John. It's such a pleasure and an honor to be here. Thank you, Norman, for the very kind invitation, especially this weekend. So thoughtful of you, John. You'll learn why I'm very much of a fan of speed. So that's very nice to be here during the Formula One Grand Prix. So it's very difficult to be on the stand after Dr. Lael. You know, it's a big task, but I have to say, she really set the stage for, again, I must have done something to deserve really, where do we stop? And so I talked to Dr. Spicer about, well, this is about the timing, adjuvant, neoadjuvant. No, I want you to define the success. Like, okay, we'll try to do that in 10 minutes. You all know very well why neoadjuvant is very important for our patients with resectable lung cancer, for many other solid tumors. What I really want to focus today is really on how can we use the translational correlates and the results from biomarker analysis from our studies to really define the success and understand where do we stop. So let's start with the surrogates. I think Dr. Lael has done an incredible job really and facilitating me in summarizing this. Historically, to neoadjuvant platinum-based chemotherapy, MPR rates in resected tumor 15 to 20%. And historically, PCR rates were not that common, so approximately 4%. But most recently, we have learned several meta-analyses. This is probably one of the most recent ones from Dr. Patrick Ford and colleagues at Hopkins, where there is really an association between PCR and OS CFS after neoadjuvant therapy with a number of studies pulled here. So these endpoints have been really used over the past few years in trials testing neoadjuvant therapies. You all know this data very well, presented by Dr. Girard today, published by Dr. Ford. So PCR rate to neoadjuvant nivolumab plus chemotherapy in the CheckMate 816, 24%, absolutely encouraging compared to 2.2%. And you can see on the right the updated 3-year survival that Nick presented this year at the European Lung Cancer Conference. So very encouraging as a ratio of 0.68 with a continuous separation of the curves with nivo chemo as compared to chemo. But is this all that we need, as Dr. Lael started off for me? Are really the PCR or the MPR sufficient? Well, we know from the CheckMate 816 that PCR could be an early indicator of benefit. You can see this separation of the curves between nivo chemo PCR as compared to nivo chemo non-PCR. And even in patients with no PCR, the nivo chemo seems to be really beneficial compared to the chemotherapy. But is that all that we need? Well, the authors of the CheckMate 816 really did a very nice retrospective analysis in the resected tumors only, and look at categories of residual viable tumor in the resected tumor specimens after nivolumab plus chemotherapy. And you can see here that patients with 0 to 5% residual viable tumor had a 2-year EFS of 90%. And this benefit really drops as that category of residual viable tumor grows. As you can see, a worse survival for patients with more than 80% residual viable tumor. And you can see that MPR seems to be promising from the very first pilot study that Dr. Ford published in 2018 that Dr. Lael presented. So you can see here the 5-year survival with nivolumab monotherapy for patients with MPR. There is an improved recurrence-free survival as compared to those patients without MPR. In the NeoStar, shorter follow-up for the nivo plus EP and the nivo combined, as you can see on the left at time of publication in 2021, but you can see a numerical trend favoring the MPR patients as compared to those with non-MPR. And on the right, you can see from the most recent publication from the NeoStar, nivolumab plus chemotherapy and nivolumab plus ipilimumab and chemotherapy, you can see that definitely the MPR and the PCR patients seem to have a better benefit in terms of event-free survival as compared to those without achieving these surrogate endpoints. Well, what about tumor PD-L1 and ctDNA? I won't really go into detail given the fact that you already heard much about the ctDNA, but let's look at the PD-L1. So for patients with a negative PD-L1, still some benefit from the CheckMate 816, and I will focus on the neoadjuvant for the scope of this talk. So 0.85 as a ratio. And look at the patients with PD-L1 positive disease, 0.41 with the 3-year updates from the Girard 0.46. Although not shown here, if we look at the 50%, we have even even a greater separation of the curve. So definitely PD-L1 seems to be an important factor for these patients. And if we think about PD-L1 and PCR, we have even better outcomes with no relapses on the New England Journal of Medicine paper. You learn about the ctDNA, so I'll go very fast here. So patients who had ctDNA clearance after 3 cycles of neoadjuvant and nivolumab plus chemotherapy had greater rates of pathological complete responses as compared to chemotherapy. And as you can see on the right, we have a nice separation of these curves, but this is also true for chemotherapy as well. So we can mention that the ctDNA clearance is a prognostic, but not predictive as of yet. This is the case as well for the NADIM2 from Dr. Provencio. Very wonderful work. Remember, on the NADIM2, we have a perioperative strategy with the adjuvant nivolumab for 6 months after surgery. We definitely, excuse me, PFS here being improved by lower level of ctDNA, as you can see from this separation of the curves. So what about really the bread and butter immune-based and gut biomarkers to identify those patients that can really benefit from these therapies, and what therapies, what combination of therapies? So beautiful data presented by Dr. Girard at this European Lung Cancer Conference from the Checkmate 816. I really do want to commend the authors for running this analysis in baseline tumors. It's very challenging on a neoadjuvant platform really to have that complete sandwich, right? As Dr. Spicer mentioned, the pre and post, so the bun on the top and the bottom. And here really we have the baseline 4-gene inflammatory signatures with CD8, STAT1, LAG3, and the PD-L1. You can see that higher expression of this combined score of 4 genes at baseline is associated with a greater proportion of patients with PCR as well as MPR. And this is a very critical because it allows us from baseline to identify those patients that perhaps will benefit from these therapies. From the NeoStar, combining nivolumab plus chemotherapy and nivolumab ipilimumab plus chemotherapy, we performed nanostring analysis on the resected tumors after therapy. And you can see here that we had a very nice enrichment in scores for T cells, NK cells, B cells, as well as markers of tertiary lymphoid structures that we have all learned are associated with tumor responsiveness to immunotherapy across several cancer types. But what is striking to me, if you look at these panels, is not just the fact that there is an increase in the enrichment score in the EP-nivo chemo compared to nivolumab plus chemotherapy, but if you see at the right portion of each panel, you can see that there is a higher enrichment in responders as compared to non-responders. And even between responders across the 2 arms, there is a trend toward improvement in this enrichment when we add the ipilimumab. So this is very important in trying to understand who are the patients that will benefit from the addition of CTLA-4 while maintaining the chemotherapy into the regimen. We corroborated this data with a single cell RNA sequencing analysis, again on resected tumors from nivo chemo and nivo chemo EP. I want to emphasize here resected tumor as well as adjacent uninvolved lung that really allow us to understand really the differences in treated lung parenchyma and tumors in the population of lineages after therapy. You can see here from the bottom that patients treated with EP, nivo, and chemo had an enrichment in CD8 terminally differentiated effector memory CD103 positive cells, CD4 granzyme K positive memory cells, very nicely B cells as we think about the T cell B cell interaction within the TLS. The NK cells, which seems to be really a recurrent type of a population, immune population, as Dr. Leil mentioned also from the LCMC3. The CXCL9 positive tumor-associated macrophages, the classical monocytes, and then a very nice reduction in the Treg population when we added the ipilimumab. And then speaking of how can we use this data for understanding who is responding or not, you can see from this scatter plots that B cells and M2-like macrophages were really negatively associated with the percentage of viable tumor or residual surgery, really telling us that perhaps these populations might have a role in dictating response. As Dr. Lane mentioned, I'll be very fast here from the Neo Coast. So thank you for having all the schemas well done for me. Of the Neo Coast trial here, we, together with Dr. Ford and Dr. Spicer, this was a wonderful translational window of opportunity trial where really the goal was not to compare the NPR or the PCR with a robust statistical power, but really to understand after a short window of immunotherapy as a single agent durvalumab or in combination with novel immuno-oncology agent, as you heard, we could see some translational signal that would help us to design more rational next generation trials. As you can see here from the combination of durvalumab and oleclumab, the anti-CD73, we really saw systemically, so in the blood, when we compare baseline as compared to post-treatment samples, an enrichment and upregulation of genes involved, again, a recurrent theme in B-cell activation, antigen-presenting cells, and T-cell co-stimulatory pathways when we look at patients with NPR as compared to non-NPR. This is data that Dr. Spicer presented in follow-up at ESMO annual meeting, the Congress last year, where again, very nicely, so encouraging to see these molecules and this population of cells being recapitulated across trials and in responders, so whole transcriptome RNA sequencing in resected tumors as compared to baseline really gave us the opportunity, looking at the delta, to have an increased expression of genes and gene signatures, again, associated with NK, CD8, cytolytic T cells, as well as CXCL13, which is an important molecule as part of lymphocyte recruitment and as part of that T-B cell interaction within the TLS. So what about gut, so host-based biomarkers? So this was an incredible team effort from the team at MD Anderson, led specifically by Dr. Cepesi from thoracic surgery, who was the co-PI of the Neostar trial. We really did an incredible effort in collecting stool at baseline and post-therapy, even throughout COVID. So I want to also commend the patients for being compliant. We had an incredible success rate. And by just performing 16S, no whole genome here, you can see that the usual suspects, so the Akkermansia and the Romanococcus, the increased relative abundance of baseline species of Romanococcus and Akkermansia was associated with NPR, specifically to the combination of nivolumab and ipilimumab. And these bacteria, specifically the Akkermansia, was also associated with what we call a favorable TCR clonality or reactivity in the resected tumors. So what about tumor molecular alterations? You heard so much already from Dr. Girard, but from the Neostar Nivo Chemo and Nivo Chemo EP trial, we did some post-hoc analysis in patients who had available NGS at baseline or in the resected tumors. And you can see here that in panel A and D, we really didn't see any significant difference in the amount of percentage viable tumor in patients with known EGFR mutant or ARC range tumors as compared to the wild type counterparts or across between treatments. But very interestingly, as you can see in B, C, and E and F, definitely in patients with a KRAS mutation or a TP53 alteration, there were less viable tumor if there was, again, an alteration as compared to the wild type. And this benefit seemed to be greater with the addition of ipilimumab, as you can see in E and F. And this really recapitulates what we learned from the metastatic setting, where KRAS, specifically with some commutations, and we've learned from the Poseidon, as well as from the 9LA, seem to benefit from combination immunotherapy. The LCMC4 will be an incredible trial. Dr. Cepesi is the PI of the leader, that will allow us to screen these patients with blood NGS for oncogenic drivers, and then these patients will be matched to their specific trial for inhibitors of specific actionable drivers. This will be an incredible trial that will really tell us more about the role of neoadjuvant and perioperative targeted therapies for these patients. So take-home points on what we should do. We definitely learned that PCR, NPR, or even a category of a percent residual viable tumor and EFS have definitely defined important success, but there is always room for improvement. I hope I convince you that probably we should look forward to a composite of tumor microenvironment, host biomarkers to really tailor treatment to specific population of patients. And again, I hope that we see more and more trials where it's mandated to build in a pan-sample collection to really learn who are the patients who will benefit, who are the patients that will be resistant, what should be doing those patients, and how do we intensify or de-escalate therapy in the adjuvant setting. So this is really my, what do I think about it when I think about what will define success? And it's really, again, reverse translation, built in with mouse modeling, which is very critical to me, as well as an integrated multi-omics approach to really understand what to design next to cure our patients with lung cancer. And so I was going to put here some Ferrari, but then I thought, well, everybody's going to know I'm Italian, and so that theme is going to be recurrent. So, so I love Rich Strike. Rich Strike was an incredible comeback last year. I'm a fan of the Kentucky Derby. So Rich Strike was number 21, really no chance to win the Kentucky Derby. So you can see him there really just after the starting line. And then you can see at the finish line, Rich Strike probably is our neoadjuvant, or maybe perioperative, we don't know. And then epicenter number 2 is our adjuvant, and then we have the perioperative with Zendon, which I understand this year is going to really try to get the podium. So we'll see what's next. Thank you so much.